Good evening, everyone, and thank you for joining our Men's Health webinar. My name is Kara. I'll be your host of tonight's event. We'll start with a couple quick housekeeping items and then I'll introduce our speaker. First, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask can only be seen by myself and the physician. We love collaborative presentations, so if you'd like to ask a question, please type it in the chat box at the lower part of your screen, and we'll save time at the end of the presentation to answer as many as we can. The presentation will last about 45 minutes and will be, will be presented by Dr. Robert Chan of MarinHealth. Dr. Chan joined MarinHealth out of Houston Methodist Hospital. Thank you, Dr. Chan, for giving up your evening to offer education to us. I know you have a lot of great content to cover, so I'm going to turn it over to you to introduce yourself.
All right. Hi, everyone. Thanks so much for the introduction, Kara. And thank everyone for taking some time out of your evening to come spend it with us to try to hopefully learn something new about some men's health conditions that maybe you or your loved one is experiencing. So a little bit about myself and my family. We're originally from the South, and we just recently moved to California about 2 years ago. And so far, we have been very happy here. So everybody in the community has been very warm and welcoming. So we'll get started. This slide is just a quiz that if you want to kind of get a baseline kind of as we're kind of going along with the presentation, you can just take your phone, open your camera, and then just hover it over this QR code here. And then it'll take you to a quiz to just kind of give you an idea of kind of like how bad is your ED compared to other people. Now, if you don't have ED and you came to this talk because you're interested in like incontinence issues, then take a second and take out your smartphone, and you can go ahead and take a picture of this QR code, and that'll take you to a different quiz that'll kind of give you an idea of just how bad your incontinence rates. So the first topic that we're going to talk about tonight is erectile dysfunction. What is it? As you probably know, it's inability to get an erection or maintain an erection firm enough to have sexual intercourse or get to the point where you can orgasm with it. Now, this is like something that's super common. Almost 1 in 5 American men who are 20 years or older experience ED in their lifetime. And then when you look at the men who are 40 and above, almost half of them have some amount of erectile dysfunction. So really common, about 39 million people have it, but necessarily they may not talk about it that much. We'll talk a little bit about the physiology of the erection process. Whenever somebody gets aroused, it helps stimulate the nerves that that innervate the penis. And what ends up happening is that the blood vessels that cause blood to go into the penis open up, and a bunch of blood goes in, and the penis becomes erect. And as a result, the veins that normally drain the penis end up getting compressed so that the blood kind of stays in place. Now, with erectile dysfunction, that process kind of gets interrupted for several reasons. The 3 main physical causes are vascular, which is something like atherosclerosis, where there might be a black plaque buildup inside the arteries going to the penis. Diabetes, where the sugars in the blood can kind of gum up the arteries as well. And then also medications, like there are certain hypertension medications like beta blockers that are kind of notorious for causing erectile dysfunction. It can also be a result of prostate cancer treatment, especially if somebody's had their prostate removed. It just kind of damages the nerves that supply innervation to the penis. And then what's important also is that Sometimes ED can be a precursor to diabetes or heart disease or vascular disease. But just overall, as you would expect, it has a really negative impact on people's quality of lives. So one thing I wanted to talk about specifically was erectile dysfunction and how it kind of relates to the heart. A lot of times when somebody gets diagnosed with ED, they may develop symptoms of heart disease 2 or 3 years later. And so why that's important is that, this is sort of that, bird in the coal mine kind of scenario where somebody who has ED, it can be, sort of a warning sign that somebody may have coronary artery disease. And this happens in almost 70% of cases. And I'll show you why. If you take a look at this picture on the bottom with the artery diameters, you see the penile artery here on the left. It's about 1 to 2 millimeters. And then next to it is the artery supplying blood to the heart, which is about 3 to 4 millimeters. And so what can happen is that as the arteries in the penis end up getting affected and blocked, that leads to erectile dysfunction. Usually 50% obstruction is kind of the thought that that's when symptoms of erectile dysfunction occur. But later on, 2 or 3 years later, that same process that's happening in the penis is happening in the heart as well. And then that blood supply to the heart gets compromised later on. Another thing that a lot of times goes along with erectile dysfunction is this syndrome called Peperonis Disease. If you haven't heard of it, it's basically scar tissue inside the penis that causes the penis to be bent whenever somebody gets an erection. Oftentimes it can be painful. Some of the complications are that you can't have sexual intercourse because it's painful or that the curvature is too extreme. Oftentimes there's a lot of stress or anxiety about the appearance of the penis because it's malformed. And then also there's stress on the relationship itself just because intimacy just becomes a lot more difficult. Some of the treatment options for Peyronie's disease include something called Xiaflex, which is an injectable medication that is injected into the plaque and ends up chewing it up. There's also some surgical options like plication, incision or excision of the plaque and grafting. And then finally, penile implants. If you end up having both erectile dysfunction and Peyronie's disease, it kind of solves 2 problems with one solution. And I'll get into this in a little bit more detail later on in the slides. So some of the treatment options that you've probably heard or come across, there's 5 main ones that are FDA approved. Oral medications, injections, a vacuum erection device, a urethral suppository, and then finally, penile implants. So the oral medications like Viagra and Cialis work by increasing the blood flow to the penis. Fortunately, they're pretty effective in about 60 to 80% of people. And then one thing to note is that sometimes if you eat a lot of fatty food whenever you take it, it may not work that great. Some of the side effects that patients report to me are, headache, their face gets flushed, sometimes it causes an upset stomach. And then the patients that I always kind of am worried about giving something like a Viagra or Cialis to, or if somebody's had a heart attack before and they're taking like nitroglycerin or nitrate therapy, sometimes that can kind of interact with the Viagra or Cialis and cause a lot of like low blood pressure issues. A lot of the men, almost half, who try the oral medications eventually give up on the pills or they can stop working. And then men who have diabetes are more likely to move on to one of these other options that we'll talk about next. Something that's a little bit more effective than a Viagra or Cialis, but probably a lot more invasive, is something called Intra-Habernosal injection therapy. What's involved is injecting your penis with this medication 5 to 20 minutes before penetration. Usually it's pretty effective because the dose can be titrated up, and it's working pretty locally right in the penis, versus like the Viagra or Cialis. It has to kind of, all that medication is kind of getting diluted all throughout your bloodstream. Approximately 40% of men discontinue therapy, usually within 6 months, because of either the penis pain, or they end up developing some scar tissue that can cause like penile curvature. Prolonged erection, which is that thing you always hear about in these commercials of having an erection more than 4 hours. Or they just dislike injections. So once again, a lot of the studies have shown that people end up quitting injection therapy for various reasons. Another option that's a little bit less invasive and maybe very cost effective is something called a vacuum erection device. Now, this is a mechanical solution where a pump creates this vacuum that pulls blood into the penis, and then you put a little elastic tension ring or cock ring at the base of the penis to keep the blood in there. Most patients are pretty satisfied with this, 68 to 80%, but there are some side effects that people don't like. There's some penile numbness or coldness, pain. You can't really ejaculate because there's a rubber band around the penis. And then if somebody's on blood thinners, the process of creating this vacuum can cause a lot of bruising. Finally, talking about the most common reason people stop using this stuff is that it just doesn't work that well and they're not able to maintain a full erection, or it's just painful. So in one study, 86% of people who had undergone surgery for prostate cancer try it and then move on to other stuff. The last medication that I'll kind of talk about is something called a urethral suppository. But basically, it places this medication called alprostadil, which dilates the blood vessels directly into the urethra, and then that gets absorbed locally into the cavernosal tissue. Usually works pretty fast, within 5 to 10 minutes. Success rate isn't that great. It's only about 40 to 66%. And then some side effects are genital pain, some bleeding, low blood pressure, and dizziness. Most commonly, people stop using this because of the pain, and that they just don't get rigid or firm enough for penetration. There's a 75% dropout rate of people who have undergone prostate surgery after about 15 months. Overall, most of my patients, whenever they try this, don't really find it all that effective. And then finally, talk about penile implants, which is sort of a more permanent solution to the problem of ED. On the slide here, you see 3 different types of penile implants. Starting from the left, we have a 3-piece implant. In the middle, it's a 2-piece implant, which has a pump. And then finally, the last one on the right is a malleable implant. So how do these things work? The pump down that's placed in the scrotum moves the fluid around whenever a man squeezes on it, and it takes the fluid from the reservoir and moves it into the cylinders that are inside the penis. It's pretty effective. 98% of men report an erection to be excellent or satisfactory for penetration. And then the side effects are the device malfunctions, or there's some type of genital pain or infection as a result. Patients often ask me, how long do these things last for? And in general, at about 77 years, about 94% of them are still like fully functioning and working. So the other question that I commonly get asked about is, putting a foreign body into the penis, isn't there a risk of infection? And the way that these implants are devised these days, they're impregnated with antibiotics into the actual material so that it is much more resistant to infection. So the 3-piece one that you see here, it's designed to simulate having a natural erection, that when you want to have intercourse, you're able to inflate it so that the penis is rigid. And then when you're done, you squeeze a button and the fluid is pushed out of these cylinders inside the penis so that it's flaccid when it's deflated and you're not walking around with an erection all the time. Now, these penile implants, there's nothing experimental about them. They've been in clinical use for over 45 years, and almost 500,000 men have undergone this procedure to get a Boston Scientific penile implant. So there's a lot of good data and a lot of experience with these. So how it works. Here we go. All right, well, I'm going to skip that because I can't get the animation to work here. But what to expect for the procedure, it's usually an outpatient procedure, and patients are put to sleep so that it's not uncomfortable. It just involves a small incision, either on the scrotum or above the penis on the pubic bone. And then generally, most people are back to their regular routine or light activity within a few days. Usually after about 4 to 6 weeks, once everything's healed up and pain's kind of subsided, men can start using it for intercourse. So usually the insurance coverage kind of varies, but in general, coverage may be available under Medicare and Medicare Advantage. Usually before we do any type of surgery, we'll run it through the insurance companies just to make sure that the insurance covers it. Now we have 2 guys here who kind of share about their experience. John here on the left, this is kind of a typical story that you hear with guys who have medical conditions like diabetes or high blood pressure that leads to erectile dysfunction. He seems obviously pretty happy with the procedure. And then Cliff here on the right is kind of the other type of men we see who ends up with ED as a result of undergoing a surgical procedure for prostate cancer. So the pros of the penile implants are that overall people are pretty happy with it. 97% of men are happy with it. 98% of their partners are happy with it. It's affordable, it's long lasting and durable. I had mentioned the 7-year, 94% of them were still working. And then at 10 years time, almost 89% are still in use. And it's natural. You're not walking around with like an erection the entire time. So it simulates having an erect and flaccid penis. So there's always risk involved with any type of surgery. Not all patients are, great candidates for a penile implant. And so some of the risks that, we talk about are failure of it, pain, infection. And the other thing to kind of understand is that once you kind of cross the bridge of undergoing a penile implant, then none of the other options like Viagra or penis pumps or injections are going to be able to be useful in the future. So in summary, ED is a really common problem. We saw that men over 40, almost half of them have some degree of ED. There's a variety of treatment options. We talked about the 5 FDA approved ones, and talked a little bit more detail about the Boston Scientific penile implant as being sort of this semi-natural, long-lasting, effective solution for ED. And you can check out this website, edcure.org. It has a whole range of questions and answers to your most commonly questions. There's just a little bit of just some warning data. I'll kind of skim through this, but it kind of just talks a little bit about infection as being a possible complication, as well as once you get a penile implant, then it makes all the other options, those 4 other options, impossible. All right. So that's the portion for the erectile dysfunction. If you guys have any questions, like take a second right now and just put it in the chat box below, and then I'll try to answer all of them at the end of the presentation. The next part that I wanted to kind of talk about was stress urinary incontinence. Now, this isn't nearly as common of an issue as the ED is, but it's still fairly prevalent. Worldwide, there's about 500,000 men who suffer from stress incontinence, and then 1 in 20 men over the age of 20 have some degree of incontinence. Talking about the physiology of how somebody urinates, the bladder stores the urine, and then it goes through this urethra that runs through the middle of the penis. This sphincter muscle that's just sitting below the prostate is kind of what keeps people from urinating on themselves. And then whenever the bladder squeezes and contracts, that forces the urine through the sphincter once it relaxes. So if there's any problem in any sort of these components, then incontinence can develop. So there's a strong correlation with people who have had their prostates removed for prostate cancer. Almost 50% of people leak immediately after surgery. And then 1 year out, about 9 to 16% of men still have incontinence. Usually how I counsel men before prostate cancer surgery is that a lot of people recover, but at that 1 year mark, if they haven't regained continence at that point, they're unlikely to regain it. Now, stress incontinence can also be the result of neurological disorders, prostate surgery, such as the TURP, the transurethral resection of the prostate, radiation to the area, and then pelvic trauma, like if somebody gets in a car accident and has their pelvis crushed. As you would expect, people who have stress urinary incontinence are more depressed, causes a lot more psychological distress, causes emotional distress, and they tend to be a little bit more isolated socially. So in talking about different treatment options, we look at kind of why exactly does someone who has prostate cancer surgery end up developing incontinence. And the reason is because here you see in this picture that the prostate's removed and cut out, and then the 2 ends are reattached together, but the urethral sphincter is very close to the prostate, and sometimes that can get damaged. There's things you can do that are simple, such as reducing fluid intake or voiding every 2 hours just so that the bladder doesn't get too full. There's also interventions like pelvic floor therapy, Kegel exercises, where you try to start and stop your stream when urinating, and then biofeedback, which is when you consult with the pelvic floor physical therapist. And then there's also coping mechanisms like pads and diapers, catheters, and then penile clamps. Now, the thing with the coping solutions is that they're obviously sort of a Band-Aid. They can be expensive and problematic. As you may or may not know, diapers can become very expensive over time. And you see that if somebody's going through 5 pads a day for 5 years, that can add up to quite a bit of money here. Catheters are pretty uncomfortable if anybody's ever had one. And there's also the chance that because you have this foreign body inside your bladder, the chances of getting a urinary tract infection go way up. And then the penile clamps are functional, but often they're very painful and uncomfortable. It's basically like a clothespin that you stick on the end of your penis. Now, in talking about 2 different procedures that we can do to kind of fix the underlying solution, the first one is something called the Male Sling. It's essentially like a hammock that goes under the urethra. It's completely enclosed in the body, so nobody knows that you have one of these things. And it's pretty effective for mild to moderate stress urinary incontinence, which I would probably characterize as 1 pad per day use, maybe 2. And then 92% of people who undergo the procedure are happy enough with it that they would undergo it again. So here's a little picture of where the device goes. It goes underneath the urethra, sort of on that area between the scrotum and the anus. And it lifts up the urethra to kind of help support it and have something rigid so that whenever somebody coughs or laughs, it can kind of compress against it. Now, the gold standard for procedures is something called the artificial urinary sphincter. It's been around for quite a long time. It's completely inside your body, so nobody can see it, nobody knows that you have one, and it mimics the sphincter that you normally have because it goes around the same place. And so let me show you kind of where it goes. It's similar to the penile implant that I showed you before. It's got 3 components to it. There's a pump that goes into the scrotum. There's a cuff that works like a belt that goes around the urethra. And then finally, there's a pressure regulating balloon that acts as a reservoir for the water to cycle. And so whenever you want to pee, you press this control pump, and then the cuff deflates. And then after about a minute or 2, it automatically reinflates. In terms of the procedure, it's an outpatient procedure, pretty small incisions on the area between your scrotum and your anus, and then one on your abdomen as well. It may take a few days to return to non-strenuous activities. And just like the penile implants, usually wait about 4 to 6 weeks before turning the implant on, just to make sure that the urethra heals. Overall, in terms of like the efficacy and satisfaction, most people are pretty satisfied with it, and most people would decide to have the surgery again. Insurance covers for this. Coverage is available under Medicare. And once again, before we do any type of procedure, we always just run it through the insurance companies to check it. So this is 2 gentlemen. Both of them had prostate cancer, which is the most common indication for getting one of these sphincters. And this is, I think from my experience, I think Herschel's kind of anecdote of going down from 9 pads to 1 pad a day is pretty, it seems pretty remarkable, but I've been able to get results similar to that as well. So in summary, the benefit of doing something like an artificial urinary sphincter or a sling is that it works. It's pretty effective at achieving continence. You can urinate when desired. It's completely inside the body, so there's no components outside the body like a catheter might be, and it has a high patient satisfaction. So some of the side effects, as with any surgical procedures, there's risk. With the male sling, the main side effects are that it may not work. If it's too tight, sometimes people can't urinate. It is a foreign body, and so sometimes there can be infection or irritation. And then finally, for the artificial urinary sphincter, it can malfunction. It can erode into the urethra where the cuff is placed, and then it can also cause urinary retention and infection. So, stress urinary incontinence, this is a known side effect of prostate cancer surgery. Usually I quote it at about 10%. But fortunately, there's a variety of treatment options that can take care of it, like the sling or the artificial urinary sphincter. And then this is just some safety indication with the sling that we kind of discussed earlier. And then also for the artificial urinary sphincter. And then here's just some references that I'll kind of gloss through. And then that's it. If you guys have any of these issues and are seeking someone to kind of talk with to see if any of these solutions might be good for you, please reach out to me. This is my office number here. I'm currently taking new patients, and usually we can get patients in within about 2 or 3 weeks, and see how we can kind of help you with your issue. So at this time, I'll take some questions if anybody has any questions in the chat.
I have a few questions, Dr. Chan. Thank you so much for going through those. On the animated videos, if you did want to go back and show those, I think, so sorry, I think the little play button is in like, gets hidden sometimes in the lower left, but those are actually on both of our websites. So no worries. Some commonly asked questions that come up for patients are, what does recovery look like after these surgeries?
Yeah, so recovery in terms of, let's talk about penile implants.
Sure.
Usually, I tell people don't do anything super strenuous probably for about 4 to 6 weeks. No heavy lifting, more than 10 pounds, no swimming or hot tub, anything that might kind of get the incision infected. And then, yeah, just about 4 weeks before turning it on and trying to have sex with it. So that's the penile implants. And then for the artificial sphincter, similar kind of guidance, 4 to 6 weeks, no heavy lifting or really strenuous exercise. One thing that is important to know is if somebody is like a biker or has like a motorcycle, they probably don't want to ride that too often, just because of where that cuff sits. It can really erode, cause more issues with erosion into the urethra.